Okay with everyone. All right, so our webinar today, Language Matters, Promoting Inclusive Communication to Combat Stigma in Healthcare. Our objectives are to understand what stigma sounds and looks like in healthcare, recognizing the effects of stigmatizing words and actions on patients, to identify and also to identify and reduce stigma within your workplace. And so, as always, we start each of our webinars with a frame of reference, right? So within the SBIRT screening, brief intervention, and referrals to treatment workflow, I usually identify kind of where today's topic fits in. And ironically enough, today's topic really fits into all aspects of SBIRT. With screening, we'll talk a little bit today about, sometimes there's sort of the potential to ask perhaps leading questions. So we'll discuss how to be mindful of that and how to really be aware and to try to prevent from doing that. For brief intervention, we do understand that there are different levels of knowledge and education around alcohol and substance use that healthcare providers are given or have through their job experience. And many sort of enter the field with very little information or very little background or education unless this is your specialty. And so really understanding where our either needs lie or our biases lie ahead of any conversation with patients, I think is a really helpful way to understand where our biases are or where our stigma might lay, because we all have it, and making sure that we're doing our best to avoid that in any conversations with patients. And finally, the referrals to treatment. So we'll talk a little bit today about some maybe language or terms that may be used when talking about referrals to treatment, one in particular just referring to rehab, and maybe how to rephrase or further enhance those conversations with patients to increase comfortability. So there are different types of stigma, and just to sort of again level set as to what this means. Public stigma are negative attitudes or beliefs held by others about a particular group or individual. So we know that there are populations of people that are associated with negative stereotypes. For instance, we know in healthcare that I hear a lot from providers that anytime a patient discusses their alcohol use, that they're underreporting, or that drinkers, quote unquote, are typically underreporting their alcohol use, and so just to assume that it's more, right? And it really underlying that is distrust, right, on both ends. Not only distrust from the healthcare provider that the patient's not giving accurate information, but there's a reason why the patient may not be accurately reflecting their alcohol use, right? And it's because of distrust of the system, or how will they be viewed, or that stigma. So just being mindful that there is a public stigma around alcohol and substance use, and to be mindful of what our opinions and attitudes currently are when working with patients. Self-stigma is when individuals internalize negative stereotypes. So we know that there's a difference between behavior and the person, right? And I think it's really important to make sure we separate those two when we're talking. So troubling or concerning behavior doesn't necessarily mean somebody is a bad person. And I always encourage this when talking with children and adults, right? That somebody, I have teenage daughters now, but when they were younger, they referred to, a bad kid. The child isn't bad. Maybe their behavior wasn't helpful or wasn't good, but they're not a bad kid, a bad child, right? Same with adults, right? Bad or harmful behavior does not make somebody a bad person. Structural stigma, negative attitudes, beliefs, and practices that are embedded in the system. And so when you were hired in healthcare, assuming that you're not working in some type of alcohol or substance use specialty, right? We usually receive very little formal education on alcohol and substance use or behavior health in general. But you might have been told, oh, Mr. Smith, he comes in all the time and he's an alcoholic, or Miss Jones lies about the amount of pain pills that she's taking, or, right, we're sort of taught these negative attitudes and beliefs around people who are using drugs and drinking to a certain level, and not necessarily taught the facts and information about substance use disorders and alcohol use disorders. And then community, negative attitudes and beliefs within a community. So we know that there's gossip, misleading information, talking about neighbors, coworkers who might have substance use disorder, knowing and assuming stories about different people or families, right? Certainly helps fuel the negativity and not promote health and change. So I'm interested in hearing from you all. I am working in healthcare, and I see people in a variety of different roles here, which is great. So what have you noticed how stigma might sound or look in healthcare? Maybe experiences that you've had kind of overhearing discussions or coworkers talking, or, even in a prior job or prior role, how have you maybe had your eyes opened to how this exists in healthcare? And you could come off mute because I'm not able to see if you raise your hand. I don't see any hands raised, but. Anybody willing to share? So maybe an experience that they've had or situation that they felt where either maybe themselves as a patient or one of their patients might have felt stigmatized? How might this look and sound in healthcare, even just examples?
Hello.
Hi, yes.
You did say with yourself, I'm a younger medical assistant, right? In my own personal life, when I've gone to the doctor, they assume that I am looking for pain medication if I'm at the
Interesting.
doctor for some sort of reason. There is a stigma with giving younger patients any medication for pain, and they always assume it's to abuse it.
Gotcha. Thank you for sharing that. No, there's definitely age discrimination that you notice sometimes too, right? In addition to a variety of others, but that certainly is one, or sort of assuming what I see a lot are sort of people asking leading questions about marijuana use or taking some type of THC gummies. I think there's the assumption that all young people are doing that. And while it is more prevalent than before, again, going into that with that assumption, sort of, immediately puts the patient feeling defensive. And
Yeah.
even if you were using them, you might not admit to that now because you're sort of feeling stigmatized. So thank you, Ashley. Anybody else? Any other times when you've noticed this in the healthcare setting? All right, so I'm going to give some examples, and some of them may sound familiar, but some of them hopefully not. Oh, I set this so that it would. I wonder why it's not. Sorry, I set it so that I could click on each one and it would populate, but I think I might need to put it on presentation mode. Sorry, give me a second to, there we go. There we go, now it's working right. All right. So for alcohol and substance use disorders, I sort of separate these into two buckets. AUD, alcohol use disorder, SUD, substance use disorder. These are things that I've personally heard being around healthcare for a long time now. One related to elderly patients, maybe patients in their 60s, 70s or older. Well, they're not going to change. Why do we talk to patients in their 60s and 70s about their alcohol use? They've been doing this for 40 years. They're not going to change, right? It's an assumption and it's a negative stigma that they're not capable of changing their mind at this point in their life. I hear this more times than I can account, especially in a hospital. The diabetic in room 2, the alcoholic in room 3, right? Not referring to Mr. or Mrs. So-and-so or even the patient, but rather referring to them by their disease rather than them as a person. Sort of generalizing, right? Everyone in that family is a drug addict. Oh, I know their mom, she used drugs forever. He's probably on drugs too, right? We hear phrases like this pretty commonly. Asking the leading questions, like we talked about before, you're not smoking while you're pregnant, are you? Or you're not drinking while you're pregnant, are you? Well, you don't drink every day, right? Questions like that, rather than asking the validated screening tool questions, anything sort of with this assumption or leading questions has a negative tone to it. And again, puts the patient on defense and allows them to feel that they can't really be honest about their substance use because they're being judged. I didn't think we used the word druggie anymore, but I came across it last week, and so I added it in here because it's worth noting that using words like junkie, addict, drunkie, druggie, or they're probably drug seeking. As Ashley mentioned, right? They're probably just looking for pain medication. These assumptions or these terms really even overheard, right? I've experienced sometimes too where maybe a loved one has stepped out of the room and they're walking down the hall and they overhear the nurses or the provider talking about their mom or their spouse in the room, right? And you don't know who's walking by at any given time. So even just being mindful of these conversations in places outside of the patient room. When talking about mental health or physical health, we also hear things like, well, they did this on their own. Maybe one referring to like obesity or high blood pressure, their mismanagement of diabetes. They're doing this on their own. Well, it doesn't mean that they still don't deserve the help and our best effort. This actually just came up today. I was working with somebody who's in an inpatient treatment facility, and they were under the impression that they felt like they were told that they were just being dramatic, but that they weren't having their mental health needs met. They felt that they weren't being heard at all because the staff felt that they were just being too much, quote unquote. Or that it's all in her head, right? Well, just take a deep breath. You don't have to feel that anxious. Just think happier thoughts, right? Like kind of minimizing the effects of mental health and substance use. Using terms that I hear all the time, frequent flyer, right? That's more so in a hospital setting, but referring to patients as, a hot mess, a train wreck, a frequent flyer. We hear these terms a lot, and a lot of times, it's understandable that we're trying to lighten the mood in a setting that could be pretty stressful. But again, being mindful of these kind of terms because they for sure have a negative connotation with them. Referring to a patient as non-compliant or saying that they're just not compliant rather than really struggling to maintain their, proper medication usage or something to that effect, right? Just sort of this to me writes off a patient like, well, they're just not compliant, right? Well, there's nothing more we can do, which is far from the truth. And then one term, just because I'm a mental health professional and just kind of irks me all the time, is when people may have, symptoms related to substance use or emotional changes or hormonal imbalances, and they just refer to anybody who has an emotional change in state as bipolar, right? That is not bipolar disorder. Somebody who's happy one second, unhappy the next is not bipolar. They may be, but that is not what defines the criteria, right? Bipolar disorder is a very serious mental health concern and shouldn't sort of just be referenced off the cuff as somebody who is changing their emotional state. So what we just talked about is what it might sound like, right? Some things that we might overhear. What might it look like in a healthcare setting? This could be things that we might not even notice, right? That us or somebody else is doing. So sort of these eye rolls, the lack of patience, maybe avoiding a patient room because we don't want to go in there and deal with all of that right now. Not giving the same time and attention to certain patients, right? So when we're noticing that ourselves or somebody else, we might not notice or be aware that we're even doing these things. But I think the recognition of our own stigmas and behaviors are a really important first step. Tone, body language that displays a closed off stance, right? Closed arms, sort of facing away from the patient. I know sometimes it's hard to be able to face a patient, especially if we're sort of on a computer trying to answer the questions, but I always try to be mindful of that, so that they know that I'm paying attention to what they're saying and all about them, right? Because what they're not saying might actually be much more important than what they are saying, right? What does their body language say? But similarly, what does our body language tell them about our time and attention and our care for this patient? Minimizing a patient's health concerns or focusing just on alcohol and drug use. And this actually came up this morning too when I was working with some people in an inpatient setting. All of the health concerns, sort of when they were discussing their health concerns, it all came back to their drug and alcohol use. Well, they're probably feeling this way because they use drugs. They're probably doing that because they're an alcoholic, right? Everything coming back to their substance use rather than seeing the person as a person who may be struggling with alcohol and substance use and also these health concerns. And lacking concern or empathy, right? Again, that idea or that stigmatizing thought or behavior that they did this to themselves, right? They're choosing to drink when we know that substance use disorder and alcohol use disorder is not a choice. And certainly to the point where somebody is asking for help, they're not choosing to do this every day, right? We know from working with patients every day that they're using drugs or drinking to alleviate those withdrawal symptoms, right? To just feel normal, to not feel sick at a certain point. All right. So I'm interested in hearing from you all. So when patients experience stigmatizing interactions, what do you think are some of the consequences of that? How do you think that patient's behavior may change after that? Or any other consequences that you can think of from stigmatizing behavior? Or have you heard reports from patients who've said that they've experienced this in the past and as a result, X, Y, and Z might have happened?
Can you repeat the question?
Yes. So I'm curious to hear if there's ever been either any patient report or from what you've noticed, any consequences when patients are experiencing stigmatizing interactions, when they felt that they've been stigmatized or they felt ashamed. What might be the consequence of that? What might happen?
Not to say like a patient has said it to me, but if they feel like they're being judged or of some sort, that can cause them to make them feel worse. And then as a result, sometimes when they're trying to get better, they'll relapse or just drink more or smoke more to hide that
Absolutely.
emotion initially.
Yep, absolutely. It definitely is correlated with patients either returning to use or continuing to use and not seek help. Yep. One thing that we also notice much more commonly, I work with an OB/GYN population, but also in primary care, is when patients do feel stigmatized or actually worked up the courage to talk about their alcohol substance use and felt ashamed by it, that they don't return. Right. And so, especially, and this is especially problematic for patients who are pregnant. They go to that first appointment and feel that they can't talk to their provider, and you don't see them again until delivery, because they're embarrassed and ashamed and don't want to ask for help again. So certainly, it leads to avoidance of the healthcare system.
Heather, can I jump in, or is
Yes,
this a good
absolutely.
time? Or okay. We also see it with early discharges, patient-directed discharges a lot. People who use substances and are hospitalized are often leaving early from their hospitalization, and they attribute a lot of that to stigma. And of course, some of that is sort of internalized shame as well. But that also comes from years of stigmatizing experience in the healthcare setting. So,
Absolutely.
mm-hmm.
Yep. So I know we touched on most of these, but reluctance to seek care. Patients may not disclose their substance use accurately, leading to missed opportunities. Again, they might minimize their alcohol use, not feeling safe to be able to discuss it. Poor outcomes, it can diminish patient empowerment and have negative impact on health outcomes in general. Risky behavior, as Ashley mentioned, it could lead to increased engagement in risky behavior, and then self-isolation or self-stigma. Negative experiences with providers can exacerbate those feelings of guilt and shame that many patients are already feeling. So now is a good time to introduce Jordan. So hello, Jordan. I'm Dr. Jordan Nahas-Vigon. Oh, let me go back here. She's an assistant professor with the Johns Hopkins School of Medicine and a physician at Johns Hopkins Bayview's comprehensive care practice. And so we've worked closely with all 30 of the, not all, but 30 of the Johns Hopkins primary care practices to integrate enhanced workflow for continuation of medications for opiate use disorder. And Dr. Vigon does specialize in treatment of patients with alcohol or substance use disorder. So thank you so much for joining us today. And a couple of questions for you, but please feel free to chime in with anything else you think would be helpful. Um, has there been any specific feedback that you've heard from patients, either discussing them feeling respected or disrespected? Like what have you heard from patients on how they notice how they're treated and how they might behave following this treatment?
Yeah, absolutely. And thank you all for having me. And feel free to chime in and ask questions, everyone, because I want to make it sort of as relevant to you all as possible. But I lead the med student course on substance use disorders at Hopkins, and we have patients in recovery that come and talk to the class. And I'm always so amazed at their bravery in speaking to this, 120 person class. And of course, all the students are sitting in the back of the classroom and they're up front in the big lecture hall. So, but what they've said is that at various times in their substance use histories, everybody that we have talked to us has felt stigma in some way and shame. And one person talks about how they wake up, that when they were using drugs, they would wake up each morning and they would hate the fact that they would know they were going to use drugs that day, but they were so sick and they didn't know how to get out of that cycle that they kept doing it. And I often think about that, how we as providers, we don't see that shame and that really poor self-image that the patient is experiencing, and really is just, you know, it's hard to overcome those feelings and then to actually present to care. And we really didn't, like, if the patients are going to the emergency room, we really didn't have great treatment of opioid use disorder until very recently. And that, of course, is what Heather was talking about with part of the like systemic stigma, right? If it was another condition that we were seeing 80,000, 100,000 deaths a year from each year in the United States, then we would have interventions that we were like really getting into the emergency rooms, the primary care offices. We would be super aggressive with it. But patients would go to the emergency room knowing that they would not be treated for withdrawal, right? And that they would suffer through that, for opioids at least. For alcohol, we're pretty good at treating withdrawal early now, but that doesn't mean that the stigma isn't still there. But so getting up the courage to go to the emergency room and suffer through withdrawal is, I mean, it shows kind of like the desperation of the patient really needing the treatment. So now it's great, especially at the Hopkins hospitals. I can't speak for the other ones, but we have the addiction medicine consult. So patients can get ramped up on treatment for medications for opioid use disorder or for alcohol use disorder, and really sort of in a patient-centered way, which I think is great. But we definitely all the time hear how patients avoid the healthcare system because they feel so badly about their drug use or their alcohol use.
Absolutely. And I think that that's one of the powerful roles of people who are in recovery that are sharing their stories, is because they often share that the reason that they're in that role is because there was that one person within the healthcare system that showed them promise, that didn't stigmatize them, that helped them feel seen and heard. And they now dedicate their life to helping other people who were in the position that they were once in. And so I think that does show the power of, it just takes that one person who looks at them differently and sees them differently and treats them differently, that might lead to that change. What about how either might you or have you responded at times when you've witnessed or experienced stigmatizing behavior among patients? Maybe you noticed a patient was not being treated properly or as effectively as they might have been, or where their care might have been different from somebody else who was, say, a diabetic or had high blood pressure. So how either would you recommend to intervene, or have you intervened in order to use that moment as an opportunity for learning and engagement?
Yeah, I think that there's a couple of different levels to this. And again, others feel free to chime in if you have thoughts on this as well. But I think that there's one aspect in medicine is sort of what we call the hidden curriculum, which is what we see other people doing. And so that often includes using these stigmatized words and sort of not very patient-centered language. And then that gets modeled and that gets continued on and on and on. So one thing I like to do is just model non-stigmatizing interactions with patients and about patients. So I hear all the time somebody says, "Hey, this person's a substance abuser. What can you do to help me treat them?" So then I reflect back to them saying, "Oh, we typically don't use the word substance abuser anymore. Can you tell me what substances they're using? So I better know how to treat them." And so reflecting back, but drug abuse is all over patients' charts. So another way that I try to do it is just where I can get those nasty words out of the chart. That's sort of like chipping away at, I don't know, a huge mountain, because everything gets copied forward in charts and things like that. So, but I like to update the problem list to be patient-centered, saying, not drug user or drug abuser, but to say
Someone
person with opioid use disorder. And certainly if somebody is like in remission, I make sure to highlight that on the problem list. And then other times that I've really seen it is like, there are some surgeons here who refuse to operate on people who have an opioid use disorder, even if they're on Suboxone, buprenorphine, or methadone. And so I have, brought that up to the healthcare system, tried to understand sort of the reasoning behind that more, present them with information about why that shouldn't be the right, the standard. And so I think that it's a few different levels. It's the modeling, it's the minor system changes, and then it's really finding those big gaps in the system.
Thanks, Jordan. And I think you gave a lot of really great examples about from kind of the small one-on-one changes that you can help make all the way up to sort of the system level changes as well. I know one thing that we work on with our primary care practices is, not necessarily cutting off the medication for opiate use disorder if a patient is quote unquote not compliant or they're using illicit opioids, right? Because similarly, you wouldn't test a patient who's a diabetic to see if there's really no way, right, to determine if they've eaten anything they shouldn't have in the past week. And then if they have, then not continue their insulin or their medication, right? Like we wouldn't do that for other chronic illnesses. But the practice has been for a while to do that in opiate use disorder. And so it's that re-education of that, no, that might have been how it used to be, but that is not appropriate any longer to withhold this medication from a patient. That's a life-saving medication. So.
Yes. And I love the diabetes comparison because it is so similar in the sense that there's genetic and environmental and behavioral components that all come together into a medical disease. And we don't hold treatment of diabetes if someone's A1C is 10 or 12 or 14, right? We actually get more aggressive with the treatment. We give them more support. We give them a dietitian. We get them maybe an endocrinologist or whatever. So we do have addiction medicine consults that primary care providers can order from the outpatient setting if they have questions about those kinds of things, like continuing opioid use disorder treatment. But yes, definitely that people should not be cut off from their medication or life-saving medication.
All right, well, thank you. Just have a couple of slides left. I know we're a little past 12:30, but I know Jordan touched on a lot of these already, but ways that you can sort of integrate responding to stigma professionally. So offering compassion and support to those you've experienced stigma, so modeling it as well, but also if you've noticed something in your practice, then trying to make that wrong right to the best of your ability, displaying kindness to people in vulnerable situations. And that is one thing that I talk to our peer recovery coaches in the hospital about, that can make a world of a difference. So as Jordan mentioned, just displaying, people model what they see. So if they see you behaving just the same to substance use patients using substances as you do to all other patients, others will follow suit. Listening to the patient while withholding judgment. And I think this, again, not just judgment in our words, but judgment on our faces and on our appearance, right? Making sure that we're listening intently and not sort of acting, in a way that might look judgmental or shocked, or you drink how much, or anything in that realm where, they'll feel immediately judged. Seeing a person for who they are, right? So that person first language that Jordan referenced, referring to patients as someone with an alcohol use disorder, somebody with schizophrenia, somebody with depression, rather than, the schizophrenic patient in room 4, the alcoholic down the hall. Doing your research, right? So this is a good first step, but this is just a snippet of information, but really understanding about substance use, how it works, and passing on your knowledge to colleagues. Treating those who use drugs and alcohol with dignity and respect, just as you would any other patient. Replacing those negative attitudes with evidence-based facts, right? We hear a lot, again, especially about medications for opiate use disorder, there's a lot of assumptions and misinformation out there, but replacing that with evidence-based facts so you can appropriately have an educated discussion. Speaking up when you see someone mistreated because of their substance use. I know this is hard to do, right? Especially if you're newer, if you're younger in the field, if you're new to your practice, it could be very hard to do, but all of us do have a voice. And when we see something that doesn't feel right, it usually isn't right. So you have the ability and the capacity to be able to speak up appropriately when you see somebody mistreated. And most importantly, talk about your substance use among your colleagues to address the misconceptions about substance use, treatment options, and long-term recovery. So sort of sharing that information, joining any type of webinars, information sessions out there to just better understand as you would for other management of chronic illnesses. And just some examples, I know we touched on a lot of these, but kind of ways to replace that, those words that might be stigmatizing. So instead of addict, drunkie, alcoholic, again, person first, a person with an alcohol or substance use disorder. Rather than saying a clean urine test, a negative urine test, instead of dirty urine, the urine test was positive for marijuana or opiates. Rather than saying a former addict or a former alcoholic, so somebody in recovery or somebody in remission. Instead of they graduated a program, that they're stabilized. Instead of saying clean, that they're abstinent or abstaining from a certain substance. I added rehab on here. Again, I think that just has a negative connotation to it. And a lot of people assume rehab means inpatient treatment. I need to go for 28 days a month, 2 months, when really there's a whole variety of different levels of care. And so I've noticed that kind of among the population of patients I worked with in hospitals, when you say rehab, they think inpatient. And oftentimes, if they're kind of newer to substance use, they're not even aware that there are other levels of care. So just talking about what I usually say, especially in primary care, rather than saying, have you ever thought about going to rehab? I'll say, have you ever thought about talking with anybody about your alcohol use or talking with a counselor or, engaging in some type of treatment related to alcohol or substance use, using those words rather than rehab. And drug abuse is no longer how it's referred to in the DSM, nor should be referred to among healthcare professionals. It's active use or a substance use disorder. All right. Anything that stood out to you, or even if you just want to put in the chat, if you don't want to come off mute and talk, that's okay too. But anything that stood out or anything that you thought, I didn't know that, or that's interesting, or I'll, try to rephrase that from now on. We're not a super talkative crew, but any thoughts or insights that you've gained?
Well, nothing I don't already. I'm
Ashley.
pretty good about not saying certain things like that, but there's definitely going to be a conversation of other people that say that. Uh, so we'll talk to them.
Yes, helping each other, absolutely. Christina.
Yeah, thanks, Heather. I always appreciate you putting on this webinar monthly. It's always so helpful with great information. Not necessarily a phrase, but what I do really appreciate is your comparison of chronic disease, treatment of patients with diabetes, and treatment of patients with substance use disorder. I think it's really important for us to understand that, like you mentioned, you wouldn't withhold medication from a diabetic because they didn't eat or adhere to their diet appropriately. So I really can appreciate that analogy.
Thanks, Christina. Yeah, I agree. I mean, I think we had a prior webinar on addiction or substance use disorder as a chronic illness, and I think oftentimes it sort of gets forgotten that it is also a chronic illness and has much more similarities and differences to things like asthma, diabetes, high blood pressure, heart disease, and such. All right, so in conclusion, we know that stigmatizing language is common. It isn't always purposeful, right? The goal of it is not always to make patients feel stigmatized or ashamed, but at times, if we're not aware of what we're saying and how we're saying it, that could be the outcome. So mindfulness and awareness is really the first step in understanding what is and is not appropriate. Once you know better, you have the opportunity to do better. And start small. Think about just one thing that you can change this week and perhaps put into action.
My coworker had a question in the chat box.
Oh, sorry. Let me take a look. How do you get your doctor who has older viewpoints to start using new terms? Yes, that is not an uncommon concern. I go back to, hold on, I actually had this conversation recently. Once you know better, you have the opportunity to do better, right? I really think about the one comparison I heard once, and this may sound corny, is to like your iPhones, right? At a certain point, you're going to be able to use your iPhone for years, and there's newer versions and newer versions, but at some point it's going to stop working, right? So even if it's something that we've been doing for 20, 30, 40, 50 years, at some point, if we're still in the field and we're still working with patients, it is our obligation as healthcare providers to be able to keep up with the times, with what is appropriate and not appropriate, right? Something that was appropriate even 10 years ago may not be today, right? So once we have that education and awareness, we can't force anybody to change their ways or to say or not say anything. But I think allowing the opportunity, giving the information, having the awareness, and at least at that point, we've done what we can do, right? And it's their choice to choose to use the better, more appropriate language and information and interactions, or not use that. But I think, small reminders when appropriate are definitely helpful. Like if, they come in and say, oh yeah, that alcoholic, blah, blah, blah. It's like, well, the patient with alcohol use disorder said he's really struggling to maintain a healthy diet, something to that effect. So small reminders, and kind of as Jordan mentioned, where we can, perhaps if appropriate, updating charts and information so that that providers and other people are sort of seeing the proper language rather than seeing and being reminded of the stigmatizing language. So I think just where we can make those small changes, we can. And also, working with others who might have a harder time transitioning their language, but at least presenting and making them aware to what is the appropriate way to engage.
And I mentioned to Heather that I love this podcast called Curbsiders Podcast. It's an internal medicine podcast, but they also have an addiction medicine arm to it. And they have an episode on reducing stigma and stigmatizing language. They also have episodes on Suboxone or buprenorphine prescribing, methadone, and issues with methadone. Alcohol use disorder medications. But one thing that you can, in theory, do is say to your doctor, your provider, like, I just listened to this amazing podcast and wanted to pass it on to you. I learned a lot. Maybe if you listen to it, we can discuss it. I don't know. I know that it's not always easy.
I did put it in the chat also for those of you who are interested. And as you know, I am recording this, so I will also include the information on the podcast and this recording in a follow-up email. Christina, yes.
Sure. I'll just share too with one of my practices. They had a similar situation where the provider had some older approaches to how they use certain terms. And so I know in your slide a few slides back that you had like old versus new language. What we did with that practice is we had an implicit bias training that we conducted at MDH, and I shared some of the slides with that person. They printed it out and was like, hey, I went to this, webinar with MDH. And this is kind of a slide that they just left out. They printed it and just kind of left it there. It's a little passive aggressive approach to it, but it made them feel more comfortable because they weren't correcting the provider who was ultimately their boss as well. But it was a nice way that they kind of just like taped it up at their desk as a reminder for them, but it also triggered the provider to look at it frequently too.
That's a great idea because we do know it's a fine line between sort of suggesting and helping and overstepping. In a variety of different practices, regardless of the setup. So thank you both for the insight. I don't think I see any other questions in the chat. However, that is all the content that I have, but I am obviously open and interested in staying, answering any questions that anybody might have, either about something related to this or related to anything SBIRT and MOUD related. And I do want to thank again Dr. Vigon for joining us today and providing her input. But
thanks for having me.
Of course. Any other questions or thoughts from anybody?
Will that be emailed to us, the slide with the old verbiage? Okay.
Yes. So I will email the slides. And then what I usually do, and I'm going to stop recording now before I forget to do that. I usually record, upload it to a YouTube link because the file's too big to send, and I will send that following today as well.